Oh, good. So welcome everybody to our February 21st, 2020 webinar. I am so glad to have my friend and colleague, Elena Zendegui, back. You're probably like the Bob Hope of Johnny Carson. Do you know what I mean?
No.
He holds the record for the most number of appearances on Johnny
that's
Carson.
Great.
I think this is like your third or something.
Yeah.
So thank you.
Right. Definitely lots.
Definitely second. We know that.
Frequent Steve Kurtz flyer. That's right. For sure.
So Elena presented last time on Coping Cat for us, and I think you threw in something in a Q&A at the end that jogged me to say, hey, would you do a whole nother webinar on that? And you were kind enough to do that. If you work with kids, if you work with anxiety, you work with school refusal or in one way or another. And Elena spent a lot of time with her colleagues from Rutgers, and I'm sure after that as well, working with approaches to help kids get back to school. So I know that our hour goes super quick, so I'm going to make the introduction super quick and leave all that time for the content. We're grateful for all of you to spend your Friday afternoon with us. And without further ado, Elena Zendegui.
Thank you. Right. Hi, everyone, and thank you to Dr. Kurtz. I have no disclosures related to the information that I'm presenting today. So I'll walk you through our roadmap for today. We are going to talk a lot about school refusal. I'll give you a brief overview with a lot of resources as well at the end of the presentation. So if you want additional reading related to school refusal, which you'll see is a very broad topic, you'll have some places to go for that. I'll introduce coaching, which was originally developed for DBT, and talk about how we can apply that to school refusal even outside the context of DBT, and how we can use some of the technology that we have that's been developed and is really accessible since DBT was originally developed. There's always the question in DBT for kids and also for school refusal of how do we balance caregiver involvement. So I'll be sure to give you guys some information and thoughts about the pros and cons and the degree of caregiver involvement when we're talking about coaching for school refusal. And then I'll present two different types of coaching that we can use for school refusal. One type is planned coaching, when we know it's going to happen, and then more of what we think of if you know about DBT coaching, which is unplanned coaching, where the patient is initiating the call to us. And then there's lots of kind of practicalities that come up related to technology and to having patients access you outside of the therapy room, and some things about therapist limits and making sure like boundaries and limits are thought about. And then we'll leave plenty of time for questions as well. Okay, so what is school refusal? It is child-motivated refusal to attend school or difficulty staying in the classroom. So it's not school refusal when kids are when they don't have a school placement, or when the parents might be keeping the kids home. And we think sometimes about school refusal versus truancy, as school refusal typically being about more internalizing disorders, typically anxiety, also depression, trying to avoid things related to school, versus truancy when kids are typically kind of seeking out experiences outside of school. So they might be having daytime parties or doing more externalizing behaviors.
This doesn't evoke egosyntonic and dystonic, does it?
Can you tell me more about what you mean?
Whether the kid is happy with the fact that they're missing school or not.
Yes and no. Yeah, yes and no. I think, and we'll talk a little bit about some of the ways that there might be kind of positive reinforcement for kids who are school refusing. And while there might be positive reinforcers, which we'll talk about in a minute, that doesn't necessarily mean they're like happy and blissful about refusing school. In general, our school refusers want to be having a typical life. Ultimately, while they don't want to go to school in many cases, they also want it to just be easier if you were to kind of broaden a little bit down the road. Does that answer your question?
Yes.
Cool. So there's a number of negative outcomes associated with school refusal. So family distress, family conflict, disruption in the family's routine, difficulties for parents getting to work, especially for younger kids. Certainly a lot of academic consequences, things like problems with grades, school placement, etc., social isolation. And then if you think about the accumulated deficits of school refusal down the line, then that can become more of a major problem. So accumulated academic problems, difficulties with completing high school or going to university, school dropouts, employment problems, even financial problems down the line. So this is something that, as Dr. Kurtz mentioned when he was doing the introduction, is something that we often see and can kind of come with a little bit of dread for clinicians because it's a big deal problem that can be pretty tricky to address.
And not for the faint of heart.
And not for the faint of heart, but I'm going to try and give some inspiration and ideas about how to make it a little bit easier and more accessible for people, hopefully. You'll see in the middle of this slide, there's it says school refusal, and there's a bunch of different ways that school refusal can kind of manifest. Sometimes we'll call this the shape of school refusal. So you'll see people missing whole school days, and sometimes for really long periods of time, often after school breaks. For those of us on February break, right now you might be dreading the re-entry that comes after this week-long break for some of us. You'll have kids who are going in late, leaving early. Leaving early often involves kids texting, depending on where you are. Kids might be texting or calling their parents from school and then getting picked up or getting permission from the school to leave home. So often with leaving early, there's multiple parties involved, and so multiple places where we can kind of target intervention. Then there's missing class. So missing class is often happening for the kids who are spending a lot of time in the guidance office or in the nurse's office or taking really kind of extended bathroom breaks. Then you might still call it school refusal if there's really disruptive, intense distress around going to school. So when that might happen is on Sunday nights, you're having Sunday scaries, but it's really intense and really disruptive, or even the night before other school days, in the morning before school, before a test, you might see really intense worry, tantrums, begging and pleading not to go to school. So that we're still going to lump in with school refusal, even if ultimately there's not a ton of school days that are being missed. So there's a couple of assessment tools. You'll see in a moment that assessment is really important. And there's a couple of assessment tools that I think are really helpful. They are in the references at the end of this presentation. And that's the SRASR, which talks about kind of what's kind of maintaining the school refusal, what's the function of school refusal, and then something called the RCADS, which I can tell you more about at the end if anyone has questions about, but that's available for free in all languages and is a self-report scale for depression and anxiety. Okay, so why not just go to school? If anyone has watched a movie or a show about high school recently, you might have thought, I don't want to repeat that experience. So there's a lot of different reasons that kids might be avoiding going to school and some things that might be really aversive about going to school. So the first up here is discomfort. And what I mean by that is can be kind of general negative affectivity, somatic discomfort, feeling anxious, feeling depressed. It can have like a lot of different iterations, and it's important to understand what that means for the person who you're working with. Then you might have somatic complaints, and you can certainly have a whole combination of these, by the way. It doesn't have to be just one. You can have somatic complaints that are making it hard for kids to get to school or to stay in the classroom. So that's the stomach aches, headaches, etc. That, like, getting going in the morning, which we're all familiar with at some point, right? So they're having a hard time kind of getting going in the morning, and the part about kind of getting going, getting out of bed early morning, especially for our teenagers who have schedules that are not necessarily in line with their biorhythms, that getting going is really aversive. It can be really hard for them to kind of get over that hump. And there's performance tasks. Certainly there's plenty of academic performance tasks or other types of more social performance that kids would want to avoid. Then there's the chance of panic. So kids might be afraid that they would have a panic attack for a wide variety of reasons based on stimuli that they might encounter in school. There's plenty of peer stressors that someone might want to avoid, bullying, drama, gossip, etc., or just social interactions. And then we also hear pretty frequently actually about distress related to crowds. So navigating, and depending on the size of the school, some schools are very, very chaotic, very, very crowded, and it can be pretty aversive and tough for kids to navigate from class to class or getting into school in the morning. By the same token, there's the noise that happens in a lot of schools that can, for some of our kids, be really distressing. Last but not least is fatigue. School is tiring, and for many kids it's boring, and so they don't want to sit in the classroom all day and feel tired, especially when they might have been up late playing video games or on Snapchat or what have you. So some more reasons to stay home, and this is and this is important. I'm bringing all of this up because I think it's really important as you're designing intervention for school refusal to understand what's maintaining some of these behaviors. So what are some of the things that are positively and negatively reinforcing school refusal? So what might be nice about staying home, and if anyone's ever taken, no one here I'm sure, but like if anyone's taken like a cheeky sick day, you might have noticed some of these kind of things that are maybe nice about staying home. And as I mentioned earlier, I don't think that most of our school refusers are, you know, kind of manipulating and designing their distress in order to seek out a lot of these things. And by the same token, these reinforcers can make it even harder for them to get going when home is very comfortable. So this, some of these factors that I have up here are things we want to keep our eyes on. So I'd rather sleep in, right? Sometimes you'll hear that kids, when they're staying home from school, are playing video games or using other electronics during the day. Certainly that's very reinforcing. Some of our kids, especially the younger ones, might have some motivation to get attention or be close to their caregivers, or even to get kind of sympathy from their caregivers. And then I have a nice lunch up here because sometimes there is special treatment that happens when kids are staying home from school, such as special meals or special treats that might make it be other targets of treatment. So you can see here that school refusal is really multidimensional. There's a bunch of different things that can be going on. Okay, so what are some things, and I'm not going to go through all of these in detail, but what are some things that you might do to target school refusal? And a lot of these are things that you would be doing in the office that you might be using coaching to kind of supplement as well. So with a child, you have three kind of parties that are involved in a lot of treatment for school refusal. There's the child, the caregivers, and the schools. And as you're kind of making hypotheses about what you think is going on, it's really important to be thoughtful about which of these parties you need to target, and often it's going to be all three of them.
You keep saying parties, and I'm picturing what they're doing when they're home refusing.
Having a nice lunch, right?
Parties. No, I'm picturing the parties.
So there's, with the child, and a lot of this is going to sound like pretty straightforward CBT stuff, but with the child, you might be doing psychoeducation, relaxation training, cognitive restructuring, helping the child with self-reward strategies, training them in other coping skills. You're seeing that I'm kind of bridging CBT and DBT during this talk. So I think you can pull from a lot of DBT strategies like distress tolerance, for example, more kind of pumped up mindfulness and things like that. Certainly interpersonal effectiveness, all of that stuff can be helpful to supplement some of our more standard CBT strategies. I put exposure. I had to put in a different color on here because we think that this is really like our biggest ingredient for those internalizing kids. So we want to make sure that that's being targeted, and I'll talk about how to use coaching actually as to target or to help with exposure. Then there's social skills training. So social skills deficits might be underlying some of what's going on. So you'd want to supplement that with social skills training. Then there's sleep hygiene. That fatigue that kids want to avoid and sleeping in that that might be as a benefit of staying home can often point to some serious deficits in sleep hygiene. And so we don't want to neglect that as we're thinking about these kids. With schools, helping the schools to increase their flexibility around how the child can enter school, and the amount of kind of receptiveness and availability of staff to support this is going to vary tremendously across schools and across geographic locations. So as much as you can have the school partner with you, depending on the situation, to kind of increase flexibility so that the kid doesn't have to stare in the face of, I have to attend the whole school day, or I can stay home and not at all. If we can kind of step things up so that maybe they could start with the easiest part of the day or the easiest class, or they could go to class but not lunch, depending on what's easier or harder. And that can sometimes help to help them to kind of gradually re-enter. Schools can also help with reinforcement strategies, so reinforcing the behaviors that we want to see and reinforcing re-entry behaviors. They can either be providing reinforcers, providing things that we want them to, or giving the kid time to access reinforcers, or they can help the child, give the child space or permission to access you or the caregivers to help with more immediate reinforcement.
And that's accessing you either on site or via some of the remote that you'll be talking about.
Exactly. Yeah, I'm not going to make a lot of pitch to be accessing us often on site. So mostly it's going to be by these kind of coaching strategies that I'll walk through. So by phone or by tele or video. So then schools, by the same token, can kind of help facilitate coping skills use and give the child access to the therapist by coaching. So coping skills use might be actually prompting the child to use coping skills. It also could be having like a coping kit somewhere in the school building where there might not be like one-to-one staff attention, but the child has a place where they can go and access coping materials. With caregivers, there's psychoeducation, helping to kind of clean up and establish consistent and predictable routines, can decrease morning chaos or attempt to decrease chaos in the mornings, helped with wind down at night, helping with sleep hygiene, that kind of thing. Managing electronics, often that's going to be that sleep hygiene thing. And certainly managing electronics can help you structure things at home so that you can give additional electronics time for school attendance behaviors as well. And then the other way we want to manage electronics is typically not allowing for electronics access during school hours when the child is at home. So we're taking away that electronics reward for staying home from school. Removing reinforcement for non-attendance, so that's electronics or some of those other things I mentioned in the previous slide. And then facilitating and aiding in exposure. So caregivers might be, once they're trained up enough, they might be able to actually help with exposure on site at the school or in the community, certainly at home as well, or they can facilitate exposure.
I might ask you to reflect this because some folks are having trouble hearing me.
Oh, okay.
But since I know we have so many students,
Mm-hmm.
I think you're alluding to, but I want to make explicit the distinction between an initiating reinforcer and a maintaining reinforcer.
Mm-hmm.
Like electronics may not be the reason that they started refusing, but it sure as hell access to it sure as hell can maintain that behavior.
Absolutely. So a point that's just to reflect to a point that's being drawn out is that while a child might not be initially refusing school because they want access to electronics, so they might not be initiating the behavior because of this, because of electronics access. Once they have stayed home and had electronics access, for example, then that can reinforce school refusal. Cool. All right. So the coaching part, that's a nice overview or a big overview of school refusal. Let's talk a little bit about coaching. So like I mentioned, this many people may be familiar with is derived from dialectical behavior therapy. I'll talk a little bit about how it's typically used in DBT and then talk about the ways that it can be applied for school refusal. So in DBT, it's used, it's phone coaching that's used, typically not video coaching, but I'm sure there are plenty of applications for that. Phone coaching is used for skills generalization, reporting good news. So the skills generalization I can explain first is about helping to promote some of the behaviors that we want to see outside of the therapy room. And good news is about letting the patient get reinforcement basically from the therapist by sharing the things that the patient has done with the therapist by phone. And then repairing the relationship with the therapist. So that's more applicable to our DBT population, our chronically suicidal and emotionally dysregulated folks than it is typically to school refusers, but it's something that for you guys to know about. So when the most common application of phone coaching in DBT is for skills generalization. So that's how do I use a skill in a session, outside of session, instead of engaging in a risky behavior. And so in DBT, it's a brief structured call that is aimed at having the therapist aid the patient in coping skills use. And that would hopefully happen that the patient would use coping skills in lieu of a risky behavior. So that's DBT. If we're to kind of change gears here and talk about how it could be used for school refusal, phone and video coaching for school refusal can help strengthen treatment by helping to generalize skills. So that's taking the skill that we're teaching our patients in the therapy room and helping to make sure that they're being used outside in the community in their real lives. So part of the reason for using technology in this way is that we can then provide support much more feasibly in the context that these behaviors actually happen. So for school refusal, that's most often at home when the refusal is actually happening, or in school when kids are experiencing a lot of distress or trying to kind of come home. The other way that this can be helpful with generalizing skills is that you're providing more timely support. So instead of I struggled last Wednesday and here we are in session on Thursday, or here we are in session like 6 days later, we can provide immediate support, which we think is going to really help with learning, dragging out new behavior. So learning new skills in this really tough context to apply the skills. The phone and video coaching for school refusal allows more flexible and thoughtful incorporation of caregivers, and I'll talk a bit about how to do that and how to kind of what are some of the pros and cons to that, because that can be tricky. And it can also increase the intensity of treatment. So you could see that when I was walking through all of the different elements of school refusal, that it can be really tough to treat. There can be a lot of different problems contributing to it. There's a lot of different people involved. And so to increase the intensity of treatment, we can schedule more sessions per week, and also we could use some of this technology to get patients just more therapy time, which can make access to treatment, to a more intensive treatment, more feasible in some situations. In the same token, this can, using the technology, can cut down on therapist travel time. So, you know, in lieu of this, sometimes we would actually go to the schools if that was feasible to access patients, and that can be really expensive and really hard to kind of incorporate into a therapy practice, just from a scheduling perspective. So when you're doing video coaching with families, it also allows you to have stronger observation and assessment. So just being able, if anyone's ever done phone or home visits, excuse me, to see what's happening at home, or if you've ever seen a patient and then suddenly met their family member and you're like, oh, this is actually what's happening. So actually being able to see what's happening in the morning, for example, or in some of these family interactions, can also help you get like solid observation of what's happening and get stronger assessment of what's going on in the home. Okay, so caregivers. We've got some options here. So you can coach the caregivers as individuals or as a dyad, like a mom and dad dyad, for example, or you can work with the whole family. And there's so many different permutations of how this school refusal can present and of how families can present, that I can't give any hard and fast rules about exactly when to do what. And so you'll have to lean on your individual assessment of each family to decide what you think is going to be most helpful. I think, as I just mentioned, video can be really helpful for coaching caregivers or working with the whole family, just because it's a little easier to see people's facial reactions and so forth. Some targets for caregivers could be contingency management. So managing some of those rewards, removing some of the things that might be reinforcing the behaviors that we don't want to see. Other caregiver targets might be coaching the caregivers in helping the child. So you might be on the phone talking to the mom about how she can effectively get the child out of bed, or how she can effectively prompt the child to do diaphragmatic breathing, etc. So you could coach kind of the caregiver in helping the child. Then sometimes what we see is a lot of caregiver dysregulation. And so if you're targeting caregiver dysregulation, I want you to be careful about your role. And that can be an important target if you're looking at school refusal from the perspective of the whole family. Caregiver dysregulation can be an important target for your work. So there's a warning here to make sure that you're keeping an eye, and you may have already thought about this, make sure you're keeping an eye on your relationship with the child. So if you, especially with teenagers, are both coaching the child in their coping skills use and trying to use yourself or your relationship as a reward for the child getting into school, and at the same time you're talking to the parents about taking away the kid's phone overnight, and the child knows about both of those roles, it can become, especially in some families, kind of tricky. So in DBT for adolescents, the recommendation is often to have a separate parent coach and a separate child coach. Now, that I think is ideal in many situations if you have the resources. If you're like blessed with that resource of having clinicians on your team who have the availability and the flexibility to both coordinate with you and coordinate with you in terms of the week to week of what's happening with the case, and they're going to be on the same page enough with you that you're not going to kind of give conflicting information, then having a separate parent and child coach can be really, really helpful. And I totally understand that it's very often not possible. So then if you don't have a separate coach available, then you have to be really thoughtful about who you're going to coach, what your role is going to be, and how that interfaces with the individual, your role in individual therapy. So kind of thinking about all the pieces together.
And the limited resources on the other end of the equation, even if you're lucky enough to have a co-therapist or
Right.
a teammate.
Right. Can the family
Afford
actually
Yeah.
afford it? Totally. That's a really good point. Okay. So we have planned coaching. Like I mentioned before, there's kind of two kinds of coaching that we might be using. One is planned coaching sessions, and one is kind of unplanned patient-initiated calls to the therapist. So there's a bunch of different ways that this can work. The structure of it is going to depend on what you're trying to accomplish and some of the specifics of the family and your availability. These planned calls could be a minute to 30 minutes, depending on what you're trying to accomplish and what your limits are. And you can keep it pretty flexible as well when you're kind of designing how you want to incorporate this into your practice. So one way to use the planned coaching is in the morning before school. So that can be helpful because if it's unplanned in the morning, depending on your personal life and professional setup, you might not always be super available when kids are getting ready for school. For example, if you have your own kids getting ready for school, it might be more effective. You might actually be more available if you're able to plan out morning coaching a few days a week. So that's an advantage of having the morning coaching planned. And often for many families, that's when the most distress and problems are coming up. And it's when you can be the most powerful in terms of your intervention and the most timely. You can make planned coaching contingent on the number of days the child attended the previous week, and that can kind of aid you in figuring out your schedule as well. So, for example, if the kid attended all days last week, you might pick just one morning in the week to have planned coaching. But if they were full refusing the whole week, then you might plan for the next week to have coaching every single morning. So how might you use this to strengthen a cope ahead plan? So it's the morning, we want to figure out exactly what you're worried about today. What do you think is going to come up? How are we going to address those problems? And then you're kind of giving the child a cope ahead plan, maybe a bit of a pep talk in the morning to try and kind of get them out of bed and or out the door. The morning coaching can also be used to kind of coax the child out of bed, to help the child use skills to calm down and get out the door, or to set up exposure. So sometimes we'll want to set up exposure in the morning where the child might not be, we're not necessarily expecting that the kid's going to get to school for the whole day, but we could set up exposure to get on the bus, right? And we could use morning coaching time to get the kid on the bus or to get the kid to the school building, and you could use that morning time to get the kid out of bed, go over what the exposure is going to be, and kind of send them on their way into doing the exposure. You can use planned coaching to aid in exposure. So an example of this might be going to, say you have an exposure of going to a school building in the middle of the day. You could have a coaching call planned to set up the exposure at home, from home, or in the community, or in the car, if that's relevant, and set up the exposure. We're going to get you, for example, we're going to have an exposure that you're going to go outside the school building in the middle of the day when there might be kids, but they're not going to be like a ton of kids like there would be in the morning or the afternoon. And so you can set that up and then send the child on their way. Or you could actually bug in the ear by video, accompany the child actually in doing that exposure in real time without having to leave your home or office, which can again cut down, make it more feasible. as a reward. So say we know something difficult is going to come up, or I've sent you to do an exposure, we can have a planned coaching call where I'm going to either make sure that you're going to follow through on, or your parents are going to follow through on reward, or I might accompany you in a self-reward or use our relationship as a reward. So say we did this middle of the day exposure to going outside of the school building. I might say afterwards, we'll have a brief coaching call. You'll have ice cream, for example, and we'll talk about anime. And that's going to be really motivating to the child, right? So that might be a way that you would use the planned coaching as a reward. For coping ahead, say we know something really tough is coming up and you want to have a touch point of support that can increase the likelihood that the kid gets to school if they know that they have a touch point before their state test, where you're going to have a quick coaching call before their big test. And it can also increase the likelihood that the child stays in the school once they're there. So we know that we have this coming up. We're going to do a quick coaching call to make sure we have our plan down pat and we're ready to go into something that we're expecting is going to be tough. For example, a state test or some other stressor that we know is going to be difficult for the child. For these planned coaching calls, there's a reference at the bottom of the screen here. That is a paper, and there's the full reference is at the end. That's a paper that actually has, if you have access to it, it has a video associated with it that shows an example of how you might use the planned coaching for school refusal. And it's an embarrassing video in which I'm the therapist.
Awesome.
So there's always that.
So they would be doing you a favor by helping you with your exposure.
Mm-hmm.
Got it.
Totally. Everybody has to watch the video.
Yeah.
Oh man.
10% discount on the next webinar if you watch the video.
Yeah, exactly. Okay. Exactly. So then there's unplanned coaching. So this is the part that's kind of more closely related to DBT style coaching. And I put up on the slide the 3 different reasons that somebody might call for coaching within DBT. It's going to be very similar for school refusal. So for helping with skills use, that's the more kind of classic way I mentioned that it's used, or the more common way it's used in DBT. That follows a particular structure. There's a really great paper that is referenced in many of the slides, but I'm seeing it's not actually referenced on here. It's Steinberg, and Miller, and it's at the end of, it's in the references as well. That has a script of how you would use skills coaching for adolescents in DBT. And so that can be really helpful in illustrating the structure. And then I can also, if we have time during the questions, I can walk through what the structure is as well for helping to use skills. Next reason to use unplanned coaching call would be good news. So that can be really quick. That could be like a 30-second call. I got through my math class, wanted to let you know. Awesome. I'm so proud of you. I'll sometimes tell my kids, would it be helpful if I did a little dance? And then I'll do a little dance. And then they'll know that I'm doing something embarrassing. This is the dance. Then they'll know that I've done something embarrassing, which is sometimes funny for them. And then that's the end of the call. So that can be really quick and feasible. And then there's repairing the relationship, which I mentioned doesn't often come up with school refusal. But when that might happen is if the kid, you're in session and the kid curses you out and slams the door, and then they feel really bad afterwards. And so they don't want to wait a whole week. So then they could call you for unplanned coaching to repair the relationship. So these calls ought to be under 15 minutes. And it can be really, especially skills generalization calls, like there's something really stressful going on. I feel panicky. I don't know why. I really want to leave. Or suddenly I've been doing well, and this morning I just don't want to go to school. Then the child can call you. But these calls follow a particular structure and should be really problem and skills focused and like 10 to 15 minutes max. Okay. And then we can talk a little bit about the structure if there's time. Okay, so some of the practicalities. So there are many, and I'm guessing that might be many of the questions that have come up. How do we actually accomplish this? How do we fit it into the practice that we already have set up? So one is billing. So how do you bill? Dr. Kurtz mentioned that, well, parents, coaches are great, but you have to also think about if the families can actually afford to have that intensive a treatment. So there's a couple of different ways that you can bill this. One is by time. So the length of the call, you would typically prorate your hourly or your fee, and based on how long the calls are. Some people also make this kind of part of a treatment package. So if I'm offering you this specialized service, then my session fee is going to be higher, and that's going to include the coaching that comes along with it. The other thing is that if your sessions are long enough and you're billing through insurance and you're using teletherapy, some insurances, maybe all insurances now, will give that reimbursement, will let you bill for teletherapy sessions. And so, but the only problem with that in terms of the applications for the coaching is that often your sessions need to be like around 30 minutes, depending on how your billing works. Next thing is safety. So you want to be sure that if there are any suicidality concerns with your patient, that you're clear on what the procedure would be if any suicidality did come up, since you are accessing somebody when they're not in front of you. And certainly also when you're doing things in the community, you want to be clear on some of the other safety issues that could come up and how you would handle that. Then with the technology, there's privacy. So you want to make sure that you are clear with the program that you're using. Some HIPAA concerns can come up. There are teleconferencing programs that are HIPAA compliant that you can use. In my practice, I use VC, but there are other ones as well. I'm sure Dr. Kurtz has some ideas as well about.
I'm going to email those to folks.
Oh, great.
Ideas, yeah.
Great. He is the tech guru. Then the other privacy thing that can come up is when you're, just like if you're doing exposures in vivo in public, when you're, for example, using teletherapy in public, you want to be sure that the patient understands and that you understand how privacy would work in that situation. And then thorough orientation to all involved. And this paper at the bottom here walks through a lot about orienting to phone coaching and traditional adolescent DBT. And a lot of that's going to be similar, minus some of the safety focus, for the school refusal coaching that I'm talking about. So you want to make sure you have informed consent about all of these issues I just mentioned, and make sure that your role is clear, both in terms of who you're coaching, parents versus kids, and also if you're going to handle the structure a bit differently, then you want them to understand that. So for example, those super focused skills generalization, unplanned coaching calls, you might want to have your role be really clear. I'll sometimes tell people I'm gonna be a little more focused and curt than normal. That's just because I want to make sure I'm helping you and not because I'm mad at you or anything like that. You want to be very clear about the rationale for the calls. So why are we doing this? What's the point? And I gave you a lot of different things that calls might be helpful for. So you want to make sure that for your specific cases, you're ironing out for the patients, what's the purpose of the call and when they're supposed to call. And then, like I mentioned, the structure of the calls as well. So what's going to be like 1 minute, what might be 30 minutes, etc., depending on how you're using the coaching calls. So another thing that might have come up is thinking about, in terms of the practicalities, your limits, and so how you could actually feasibly incorporate this into your practice without getting too burnt out. So you want to make sure you're keeping an eye on what your limits are in terms of time, number of calls, number of patients you might be offering this to, length of the calls, etc. And so keep a really close eye on that and be sure that you're noticing what your limits are before it's too late and communicating it to your families before it's too late. And we also have the stance that your limits can change over time, right? So if you think about, say you're offering morning coaching to a family and then you have a kid, you know, so then you might need to change what your limits are about morning coaching or something like that. So we do have, well, I'll go to the resources here and then I'll come back to the structure. So this is the list of resources I've been referencing. There are some good references related to childhood anxiety treatment. There's a couple of questionnaires in here. There's the 2 papers that I mentioned with the video, that's 2015, and the Steinberg, and Miller 2011 paper that has the script in it. And then there's some DBT references as well. So Dr. Kurtz, do you want me to come back to the structure of treatment real quick? Okay, yeah. Cool. So I'm gonna come back since we have a couple minutes and talk a little bit about the structure of the skills coaching calls. So first you want to address any safety concerns if that's relevant and get that targeted or resolved as quickly as possible before anything else. So for most of our school refusal calls, you'll be starting not with the safety piece, because often that won't be coming up, but sometimes it might, and be talking to the child about, or the parents, what's the reason for the call. Then you might ask them what skills they've tried. So what have you already tried? Because they may have already tried things that haven't worked, and then that would change how you intervene. And then you would elicit skills ideas from them. Did they have any ideas about what might work? Or you might be suggesting ideas for them, helping them to brainstorm, or suggesting additional skills. Then once you've identified what skills might work in the situation, getting commitment from them to follow through with using the skills. And then troubleshooting, what do you think is going to get in the way? So being sure that you're kind of planning ahead for what might go wrong and addressing that so that they have a sound plan. Then you might also make a plan for follow-up. Sometimes we'll want to say, you know, can you give me a call back afterwards and let me know how it goes? Or once you get through this, then we can celebrate with, you know, talking about anime for 5 minutes or whatever you think might be helpful for the child. And then we'll stop there.
Super. Can we take it off of the PowerPoint? Just go to the visual there.
You just need
It's okay.
PowerPoint. Oh.
Awesome.
Can you check?
So we got some great questions online.
Oh, good.
So from a conceptual point of view,
Yes.
there are a couple of things that strike me as themes. First of all, the power of the therapist attention in this process and the recognition that the relationship is a really, really, really big part of this work. Not that it's not a big part of other work. Right. But it's a really big part of this work. And then related to that, whether the attention is an antecedent, the way we use it, or a consequence. And if it's a consequence, you drank the Kool-Aid a long time ago. So I just want to remind people that your attention is not used to reinforce school avoidance.
Right.
And so I wondered if you could draw a parallel for people who may know a little bit about DBT. In DBT phone coaching, you don't want the call from the emergency room after the kid has cut themselves.
Right.
So can you describe that distinction and then talk about how it applies in this situation?
Sure. So in situations, which hopefully we're often in, where you believe that you have a good relationship with the child and that relationship can help to reinforce behavior. And I like qualify it a little bit. Yeah. hopefully appropriate behavior, but could also be used accidentally to reinforce inappropriate behavior, then you want to be really, really thoughtful about how you're applying your attention to the situation, right? So you want to make sure, for example, if you have a really great relationship with the child, that you're not giving them a lot of positive attention or a lot of time when they're doing the undesired behavior. So for example, when they are home from school. So if can they still see the slides or no? No, okay. So I did that, I showed that slide with all of the different things that might be going on at home, that would be reinforcing. We don't want ourselves on there as well, right? Next to like having a nice lunch.
When you edit the slides, you'll put that with like another color.
Yeah, exactly.
Yeah.
So you don't want yourself there as well. So you can then use your relationship and your attention to reinforce once they have done the desired behavior. So once they have gone to school, once they have used a coping skill, once they did get through that test, then you would be applying your attention. If you're using it, that being said, right, and you want to really watch how it's working before, maybe once they're like help seeking, you could use your attention for help seeking if that's a behavior you want to reinforce. So that's when you might be having the call when they're struggling and trying to figure out, how do I stay in school right now, right? So then you can use your attention there and use your relationship to help validate and cheerlead the patient to get into school or to stay in school.
So I'm going to just kind of summarize then.
Yeah.
Our attention is an antecedent to stimulate the desired behavior is one thing. Our attention after the fact to reinforce the desired behavior is another thing. And our inadvertent attention when they're just not coping and we're kind of hanging out with them while they're not even struggling to get back in the game is a whole different thing, right, to be especially aware of.
Right. So if you're trying to kind of generate the behavior as that antecedent and you're not kind of getting anywhere, and then it's becoming just you're reinforcing refusal or unwillingness, then you would want to pull away.
And I think what should be obvious to people listening, because you emphasized it enough, is that the focus is on the use of skills, not just talking about how frustrating it must be not to be able to go to school.
Yeah.
I know that's obvious to you, but I just want to emphasize
I'm glad you are, because I think especially if you're thinking about what is the purpose of this context outside of session, outside of session time.
Right.
The contact outside of session time, I mean, hopefully we want it to be like very focused and efficient and aimed at really helping increase the quality of exposure, for example, and to generalize skills.
So far as you know the research, are there comparative studies with and without this style of coaching or the dosing of it? And are we there yet?
No, we're not there yet. So
because I would think generalization has got to be better with this, and relationship and satisfaction ratings probably are better.
Right. So in terms of, we're not fully there. That's the short answer.
Just a heads up, a lot of questions were around the ethics practicalities of telehealth.
Yes.
And for me, one of our country's best experts is Mary Albert, who's done a lot of work with APA, and she'll be doing our webinar on the 15th of May.
Oh, cool.
And we can come back to some of these specific questions. One of them that I know we come up with is, if a kid is on a secure phone with you, the kids in the background, they haven't consented to be in this interaction. So kind of managing some of that must be tricky at times.
Yes, definitely.
One of our staff here is homesick today, but she had a good question.
Oh, and still dialed in.
Huh? She's still dialed in.
Amazing.
She's a trooper. Kate was asking, when you get the predictable response burst, extinction burst, when the parents try and put limits on electronics, what's some advice you might have or considerations for the parents as they go to set those limits? And we know there's going to be a response burst.
Right.
Extinction burst.
So hi, Kate. and good question. Coping ahead, I think making sure that they understand before they put that in place. So often that's going to happen in the office, making sure that they understand that that burst is going to happen, and that it's going to get better, and that they're being really thoughtful about when they would remove the electronics, so that they, not when they're sick or going to a wedding or something like that, but making sure that they're aware that they are going to need to kind of shelter in place as that's happening.
And I'm guessing you're working with school-age kids and mostly teens.
Mm-hmm.
And I'm guessing you've already partnered with them that although this will be challenging for you, getting their consent that you shouldn't be on electronics when either you should be asleep or you're not in school. So it's
Yeah.
not like a surprise that you're being pulled over for speeding, so to speak.
Yes.
That doesn't mean it's easy when you get in the moment, but
Yeah.
would you ever tell a parent to do this if the kid hasn't understood this is what's coming?
No, I mean, not really. No, I don't think so. And I would also say that, like, the kids might not be surprised. I think sometimes the kids are surprised that they're being pulled over because their parents are changing the behavior.
Wait a second, I've sped on this highway before. I never got
Right.
pulled over.
And
What's
then
the deal?
exactly. And they might be pretty outraged.
Yeah.
Because often, in a lot of our kids' social groups, there's a lot of contact going on, like, throughout the night between kids, and so they feel like everybody else is allowed to do it.
So half of my life is very externalizing aggressive kids.
Mm-hmm.
So the response burst that we might expect with an externalizing aggressive kid is one thing.
Mm-hmm.
But anxious kids, when you're setting limits, can also get aggressive.
Yes.
But I'm imagining, by and large, it's a different order of magnitude. It's whining, complaining.
Yes.
It's not taking out a knife. It's not throwing your phone out the window of the 10th floor apartment.
Right. Usually not.
Right.
And I think, and when you're helping parents expect what might happen, they need to know their kid.
Yeah.
Certainly, there are kids with school refusal who you might expect would kind of go darker or go more externalizing. And
I
then
guess
you want to be
darker is
prepared.
also threatening self-harm.
Mm-hmm.
Yeah.
Sorry, that's where I went. My DBT brain went when you said grab a knife.
Oh, my
So your
externalizing
PTIT brain went somewhere else.
the other direction. Knife against you, not against me.
Okay, all right.
I would also think that escape would be one of the main things that would
Mm-hmm.
drive these kids, which might end up being pretty extreme if they were to just flee.
You
Yeah.
want to reflect that?
So the question was, does escape also drive some of these kids because they want to just flee? So you mean that they might run away?
Like
I've
to
never-
get out of school or to
Yeah. Oh, I have seen that.
get away from their
Mhm.
parents who are trying to get them to go on the bus or into the car.
Yes, that does happen, and that's where you want to, if you think there's a chance of that. I've only seen that like maybe 1 or 2 times, but it has happened. And I think what you have with our anxious kids is these competing demands of like escaping from school, but then like the things that are anxiety provoking about the real world. And so you might get escape. I think I had a child who left school, but then just went like to the schoolyard. So
Right.
so that because he didn't want to go actually far into the community or anything like that, because that was scary too.
This is that difficult point where I got 2 minutes and I got to like choose questions
Okay.
really carefully. So I'm going to leave you with the 2 questions and you can apportion them as you will.
Okay.
One astute attendee was saying, asking, do you use this all the time, or is it with your non-responders to a more standard protocol? And if that's the case, what can I look out for in my assessment to let me know which kids may need this? And then
Great
the second
question.
question was,
Mhm.
obviously you need huge coordination with the school. What's kind of your first line of who you think your point person is going to be on the school end?
Okay. So for the first question, the question of like how many of your kids can you use this with is going to entirely depend on the logistics of your practice and the composition of the patients in your practice, in terms of how much bandwidth you have to use coaching outside of session, and certainly what you might have going on in your personal life as well. Because and even the other patients who you might have. So there was an interesting study in the DBT world where they looked at the frequency of phone coaching in DBT, and they found that the average number of calls was relatively surprisingly low, but there were these extreme outliers that were really burnout inducing. So if you have one of those kids on your caseload who's really tough and eating up a lot of time, then you might think about not offering it to your incoming patients. Who needs it? I would look out for the kids who have really extensive histories of school refusal. Or if you have somebody who has a brand new behavior that you might be able to nip in the bud, you could offer short-term coaching to
that's
them.
interesting. So not necessarily for the more severe and intransigent, but
If you had like brand spanking new
strike
school
while the iron's
refusal,
hot. Yeah.
exactly. I'm just going into 8th grade. I'm not going in. Then you might use it for them.
Okay.
Yeah.
More to ask about that, but I'll let you go on to the other question about setting up a point person on the school end.
That's going to depend very much. I think there's so much variability between school districts and states and cities that it's hard to give a consistent answer. Usually what I'll do is ask the families who the people might be in school. That's my first question is, who knows your child best?
And my go-to is to the kid, who's the one adult. If there was somebody you were going to go to,
Yeah.
who would it be?
Yeah. That's great.
Well, disappointingly, it's often that they have nobody, and that's kind of how they're in the situation.
Right.
Not how they're in it, but
often it's guidance. But again, that can vary tremendously.
Yeah. All right, we are at the end of another fabulous webinar. Thank you again for sharing your time with us. And for those of you who are doing this for CEs, you'll get a link in just a few minutes, and we strongly encourage you to do that very short survey. You actually get a reinforcer at the end. You get a PDF with your CE certificate. So we hope you follow through with that, and then we can send that feedback on to Elena. So thank you so much for joining us, and thank you.
Thank you
Very much.
Bye, everyone.
Okay.